Well, thank you so much. Welcome, everyone. It's been a month, I think, since we've had one of these, and just excited to see all of you out there and, amplifying the voices of important people that are not being served by our current healthcare system has been a passion, I think, that you've known about of mine for the last at least year and a half, if not more. But I think we're really sort of shining a light on the sort of inadequate care of many populations that are important to be serving, not just affluent white males who are married in the US. So really wanted to bring you some really out of the box speakers and some really, thought leaders and I think visionaries, as I had posted on Twitter, who are really doing this work, not just thinking about these things and identifying problems, but really trying to make a difference. So I wanted to introduce to you today Maria Teresa Ferretti. Dr. Ferretti is the head of, she has a PhD. She's a neuroscientist and chief scientific officer at the Women's Brain Project in Switzerland. And she has done some amazing work. Definitely, I've been following her work on Twitter and throughout social media platforms, but really trying to amplify the need to care about women and their issues from a neuroscience perspective. And then Professor Moro, who is amazing. She's got an MD and PhD. She was actually at my where I went to medical school for a while in Toronto. She was actually my sister who was on an internal medicine rotation on neurology. She's an internal medicine doctor, went on to become an endocrinologist, but had the pleasure of working with Professor Moro as her attending on the neurology and patient service at the University of Toronto. So we go way back just from hearing great things. She has an amazing sense of humor and just an energy and advocacy sort of fire that I just love and have really learned from in the last year. And we just submitted a paper together to the Movement Disorders journal that I've been allowed to say is, in its final revisions, and hopefully will be published soon, really identifying gaps in care and research in women with Parkinson's disease, living with Parkinson's disease. So this has been, a pleasure to have Professor Moro on, and she is she's a neurologist and the director of the Movement Disorders Unit and chair of the Department of Psychiatry, Neurology, Neurorehab, and Forensic Medicine at Grenoble Alpes University in France. So I wish we were all in person, actually, in the beautiful areas that you guys are living in. I'm coming to you from Southern California here, so not seeing any snow in the mountains quite yet out here. But yeah, so welcome both of you. I wanted to first spend a moment just trying to understand what has brought you passion in this space, maybe a little bit about what your career has led to doing this work so far, and just a little bit of an understanding of who you are as well. So maybe we'll start with you, Dr. Ferretti.
Sure, with pleasure. So hi everyone. It's really a pleasure and an honor to be here today. So thank you so much for the invitation. I have prepared a few slides and I will just talk over them a little bit. But to answer your question into how I came to this space, I actually, my background is being a neuroscientist and working with mice and a lot of tubes in the lab. I've been doing a lot of preclinical research. In Zurich, I actually got interested in clinical research as well. And that's when I started to realize the heterogeneity that we had in the field of Alzheimer's disease, which was my main occupation. That's what started to get me thinking that patients are not all equal and they're not like the mice, right? You have these cohorts that behave in a very easy to predict way. With clinical samples, it was a completely different story. And that's when I really started to think about this topic. And I started to ask myself, is it possible that some of this variability we have is due to sex? Very simple differences between men and women. And it just started an entire conversation with a number of colleagues. And the final result has been the Women's Brain Project. So allow me to show you maybe just a couple of slides to give you an idea of the story of this organization. Now, of course, my slides have the ability of disappear when I need to share them, but then I find them again.
Perfect.
So the perspective that I'm bringing is really the person-centric approach, because from this realization that there is this heterogeneity in Alzheimer's disease, I came to realize that actually this exists in basically any disorder you can think of, especially in the brain. For brain and mental diseases. And what really gives me passion and what really motivates me to stay in this space is the realization that actually we need to put the patient at the center of the healthcare approach, because patients are not all equal. There is this heterogeneity. Every one of them has different needs. And I'm seeing this mostly as a scientist from a precision medicine point of view, like we do in oncology, that we can characterize very specifically the pathology in different groups of patients. But that also exists, this type of specific needs also belong to the area of, for instance, socioeconomic determinants of health. So also understanding what is the environment, what are the socioeconomic conditions of a person, and that is heavily, so this both the biological and the socioeconomic aspect are heavily impacted by being a man or a woman. So we're talking about sex and gender. And so what really motivates me is that we need to tailor solutions around the patient. And if we want to do that, whether the patient is a man or a woman really makes a difference. And I see it both from the biological and the more socioeconomic point of view. And I just want to highlight that actually it's not me saying that, but it's the WHO that says that sex and gender are both determinants of health. So the type of disorders you will get, the access to healthcare that you will have, and even the response to treatment will be different if you are a man or a woman. And to this belong both biological aspects, so biological differences between men and women, and this is what we refer as sex, but also the socioeconomic determinants of health that are affected by gender, so the social-cultural construct of being a man or a woman in a given society. Very well aware that the reality is much more complex than men and women, and there are there is a spectrum that we should start studying. But it's quite for me it was quite astonishing 5 years ago when we started with the Women's Brain Project to realize that there was so little attention even to these two big groups. So we're not talking about a minority of patients, but really half of the global population, and there was so little attention to the specific needs of men versus women in a number of disorders. So I'm representing here today a group that is called Women's Brain Project, and I like to spend just 2 slides explaining to you what we are and what we do. This is a non-profit organization that is based in Switzerland. I co-founded it, and I'm currently the Chief Scientific Officer. We are a group of scientists, so it's a bit of a special group because it was born as an idea among me and other colleagues, scientists. And then we started to work with colleagues from different fields, asking also for help from patients, caregivers, policymakers. We are now working with a number of stakeholders, and our mission, what we would like to do is really to improve the current state. We see a humongous unmet medical need, especially for brain and mental health. And we think that gender medicine might help. Gender medicine is quite advanced in other fields of medicine, but for brain disorders, I have to say we're quite behind. And so our idea is to push and further study this, understand these differences between men and women and the determinants to brain and mental health as a gateway to precision medicine. So the final goal is really to give the right treatment to the right patient at the right time. Our overarching goal would be the creation of a research institute dedicated to the study of these topics, and it's not an easy task, but little by little we are trying to get there. And here is a picture of the team. Not everybody is on this, but just to give you an idea, most people work pro bono in this initiative. They just dedicate literally their holidays and Sundays and evenings to do research projects with us. What we do is mostly publishing papers, and we are talking about both primary research papers and a lot of reviews, and also systematic reviews, meta-analysis. So trying to give a sense of where we are in the literature and also identifying specific topics that need to be further studied. We organize events and we do a lot of teaching and outreach activities because we think it's important also to communicate the findings, whatever we find in our experiments, in our data. We want also to communicate this to the lay public. And I just to highlight to you, I think it's here we published the first textbook on sex and gender differences in Alzheimer's disease. So I have a passion for Alzheimer, but I'm convinced that a lot of the topics we've been studying in Alzheimer apply to a number of other disorders, especially Parkinson, and maybe I'll give you a couple of examples from that. These are some of our publications, and this is the book that I was telling you about. And I, of course, I don't want to talk about specifically Alzheimer, but I was just thinking, of a couple of learnings that we had in the past 5 years studying sex and gender differences in Alzheimer's, and something that might be of interest to this audience as well. The first learning that we had was that when we started looking at sex and gender in Alzheimer's, the entire conversation at the global level was focused on the numbers. So how many patients you had being men, how many patients were women. And the whole discussion was about that. It was also a very heated and political discussion. It seemed to be men versus women, you know, and there was another level that was really neglected and not considered, and that's what we wanted to bring to the table, which is the precision medicine approach. So it doesn't matter how many men and women you have, but when you have a patient that is a man and when you have a patient that is a woman, do they need to be treated differently? What are their specific needs? This did not exist back then, and I think this is also important in the case of Parkinson, because of course we know it tends to be more men than women, but in the end, what we should really care, I think, is really understanding the presentation of the disease, the risk factors, the biomarkers, and so on, if we really want to help people. So the lesson number one is go beyond the numbers and try to really understand the specific needs. In Alzheimer's, we have found a lot of interesting differences in terms of risk factors, in terms of biomarkers, scales used to diagnose the disease. We are still working on them, and we are far from anything that is like sex adjusted or, you know, from implementation in clinical practice. But I think that all these differences that we have found should also help and guide our thinking in Parkinson, for instance. So how we diagnose the disorder, the biomarkers we use, the scales that are used, are we considering the spectrum of symptoms that can be different in men and women? And so can we do better if we consider the presentation of the disease in men and women? Maybe that applies in Parkinson as well. And one last lesson that it's relatively recent and for me was quite shocking. We published actually a viewpoint in Nature Reviews Neurology about this. I called it the missing X factor in Alzheimer's disease. And it's actually the role of X-linked genes in the risk of, in this case, it was about Alzheimer's. And actually, what happens is that the X chromosome is huge. It carries a lot of genetic material, and it's quite shocking to realize that the vast majority of GWAS studies, so genome-wide association studies, these large genetic studies, actually automatically eliminate the X-linked genes from their analysis. It's part of the data cleanup procedure. And so we have a lot of studies published on genetic association of different genes with Alzheimer's and other disorders, but actually we know very little about the role of these X-linked genes because it's complicated, because it's a difficult statistical analysis, but in the end it gives an idea of the gap of knowledge that we have right now. And it does not apply only to Alzheimer's, I'm sure it applies to other disorders as well. So, you know, when you start digging into it and looking into it, you realize that there is a lot of work to do. There are a lot of open questions. Many of them apply to more than one disease at a time. And I personally think that if we manage to answer this type of questions, we could actually, my final goal will be to optimize the patient journey. So from the preclinical phase to the first presentation of the symptoms, getting a timely diagnosis, removing the stigma, getting the right treatment, this whole pathway and journey, I think it can be significantly improved if we realize these differences between men and women, and then there will be a lot of other differences in other groups as well, but we can start from there as the gateway to precision medicine. So this would be the, in a nutshell, what we've been doing and some of my insights.
Wow. I love that. I love that. I mean, I think that we have really missed that boat of, you know, really thinking about the whole person, understanding them from, you know, not just their sex or gender, but even, you know, the cultural context in which they are. And, you know, I think there's a lot of intersections too, right? Like some women, maybe a woman of color, or maybe have a sexual preference that's different, and really thinking about that person and what all they bring to us as doctors or healthcare providers. And then, you know, helping to, you know, sort of be bespoke in terms of the treatment paradigms that we offer them has really not been offered before. I think this has been a huge missing link in the dialogue. And I think, you know, I think the work that you're doing is really phenomenal. I can't believe you've written a textbook in such a short time, you know, with so many people that are largely working pro bono. It means that this is something that's a passion, not just of yours, but of many, many healthcare providers. And I know Professor Moro and I have joined you in that sort of cheerleading, because we really want to, amplify the voices of people that look like us, who have this disease and are living with it. And the truth is, part of what we talk about in many of our lectures these days is really thinking about, that sort of netter drawing of the old white Caucasian man who's hunched over with Parkinson's is the picture that many of us as clinicians all learned about this disease from. And so if you look like me and you have symptoms with this, with Parkinson's, the diagnosis was really missed for many years. People are told that they're, maybe it's a mental health issue, or that, that they should be on an antidepressant, and that their symptoms are often, not really taken very seriously. So I absolutely think that part of the stigma, part of re-education, part of really thinking about that whole trajectory from, understanding who gets this so that we raise awareness, and then understanding how to help people throughout the phases is such an important part of the dialogue. So commend you for that work. And absolutely, there's definitely shared things that we can learn from Alzheimer's disease and other neurodegenerative processes. So awesome. Thank you. Professor Moro, I'm going to put you on the spotlight now to learn a little bit about your, sort of background and what made you inspired, because I know you've really lit some fires around the world in this arena, not just, for patient care, but also getting healthcare providers to rally together as women in medicine. At the Movement Disorder Society, you're leading, this special group of us and helping bring us together. And then at the EAN, the European Academy of Neurology, you've also been trying to do this work. So teach us a little bit about why you're doing it and, what you hope to accomplish.
Yes, thank you very much, Indu, also for organizing this, I think, extremely important webinars, right? Because they help people with Parkinson's disease, but also the neurologists and the people, or everybody who is involved in the care, to understand a little better what are the gaps, what we still need to do, which is quite a lot. So we need to do this together, right? Otherwise, it will be very difficult. As Maria Teresa said, we are just, it is the top of the iceberg, right? So we have to discover so many things that we need to work all together to get the point. So if you want to know how I got started, as movement disorders physician, we are very curious, right? We watch, So what I noticed, I was very young, I was 25 years ago, with the first people with Parkinson who got deep brain stimulation, and it was in Italy. I noticed that women, they had much better results in terms of a benefit from DBS. So after surgery, they were very active, they were doing a lot of things, and they were a little more quiet. I said, well, I think there is a difference in the response. I don't know why women, they get much more involved after the DBS. And then I moved to Toronto. And when with the first dystonia, people with dystonia operated with DBS, who are much younger, because dystonia is a different disease, I started asking, but do you think that during your periods, there is a difference in the response of DBS? And they say, yes. I said, what? Why? It should be all the same, right? The clinical symptoms. And then we wrote a paper that I will show you at that time. And I discovered that there was basically nothing published on movement disorder and women differences. Then, I did other stuff, and then I moved back to Europe and in France, and then I started, getting some interest a little more. And Maria Teresa was actually one who inspired me, because I went to as a member of the European Academy of Neurology to one of the forums that she was organizing. And then I was thinking, why we don't do this at the European level with a task force that should be involved in pinning down the importance of recognizing differences in movement in neurological disorders, because basically there's nothing organized at a very high level which can be important for teaching. You know, you are talking about a young physician. Nobody teaches them, you know, that there are differences between men and women in neurology. Have you ever heard? No, just, you know, when you have to prescribe a medication in epilepsy or in pregnant women, you have to be careful, otherwise, who cares, right? So, no, it's a bit sad, right? So this was the reason. So we started this project, and actually we discovered that a lot of people, they are doing that, and just in small areas. So we need to put, you know, all the actors on the stage. And as I said, work together, you know, everybody small pieces, and I think we'll be successful to, as Maria Teresa said, to personalize the medicine, right? We know that there is no Parkinson's disease, there are several diseases. So, which means that we have to adapt our questions and the treatment according to the person who is in front of us, starting by sex. So I don't know if you want to take over, then we will go deeper to some points that I put in some slides. You are the boss.
Yes, the slides, and then we can have a little discussion. And I think there's already some comments coming in, and people can, you know.
Okay. So I will share the screen. So I will try to be very, very simple, because let me find out, because I have my laptop is a bit not always easy, like now the screen. Here we are. So I just want to tell first that, again, I started with another colleagues a task force in the European Academy of Neurology. There are 45,000 neurologists in Europe. So is you know, a good platform to start increasing the awareness that there are differences, right, in several neurological diseases between women and men. And this is the paper that we did years ago in Toronto, right, in which we try to understand the impact of the menstrual cycle in people with movement disorder. We realized, even if we didn't have a lot of response at that time, that young women with dystonia, with Parkinson, with tremor, they worsen their symptoms during the periods, right? It was the first time that we started to be involved in this area. And as Maria Teresa said, neurologists, we know that migraine is very common in women. So well, we just are careful when we have a migraine in pregnancy, right? But otherwise, we don't pay a lot of attention that there might be some differences if we treat men. But stroke, epilepsy, multiple sclerosis, and Alzheimer's disease, there are some differences in between the two sexes. And the sad part for physician is that we don't have clinical evidence. You know, the clinical trials usually in which the physician, they base the choices, the guidelines to decide which treatment we have to give our patients. They're not taking in any consideration the sex and the gender. So everybody's the same, you know, so let's give this drug. Maybe it works for men and women, but nobody knows if there is any difference. And we start understanding there are differences, they are very important. And if you know very well that there is a prevalence for Parkinson's disease in men. So especially in the older age, there are much more men getting Parkinson's disease compared to women, right? So, and in these graphs, you can see the big difference, right? The beginning, actually, there's no really big difference between men and women, but when you get older, the contrary to Alzheimer, men are much more you know, with the higher risk of getting Parkinson's disease compared to women. And nobody knows that. And occasionally, you know, in France, if you are a farmer and you use pesticides and you get Parkinson's disease, you are recognized as a professional disease. So because they found a link between pesticide and Parkinson's disease. But the interesting point that if you are a man and you are a farmer and you get Parkinson's disease, there is a strong link. Probably there are some genes in men which predispose to develop Parkinson's disease if you are exposed to pesticide, but it doesn't happen to women. So probably, again, as Maria Teresa pointed out, there are some genes which protects women, but not men, from some aggression in the neurons that the pesticides they do, and they induce Parkinson's disease. And this is very important, right? Because you, as you know, you will protect maybe men a little more compared to women to the exposure of pesticides. Then there has been a lot of publication in more basic neuroscience, trying to understand a bit difference between the brain, between women and men. No, I don't think that they're very relevant, but the one thing that maybe you need to know, that when we do preclinical research, so you know that we have animal models to test drugs in Parkinson's disease. Most of the time, these animal models are males. For many reasons, because are bigger, so it's easier to study them. And then they tell you, wow, if you have a female rat, is a disaster, because this female rat has the periods, it's difficult. So most of the research in the labs are with male rats. So you understand, it's not the same. So we just you know, take everything for everybody, but this is a major problem. This is a really major problem, because they discovered that for when you study pain, the pathophysiology, so the mechanism for pain in female rats are different from male rats. So if you taste a medication that are good for male rats, maybe not good for female rats. And this may be the same for Parkinson's disease. So it's very complex for us as physicians or scientists to understand that there is really a complex interaction between the genes, the environment. Some genes protects women, or some genes they're more against the protection of women. Just to let you know that it's not an easy field, but it's very complex. We can't close our eyes and say, well, we know that it's difficult, so we avoid it. We really need to be more inside this issue, and to do a little more preclinical research to improve the way that we treat Parkinson's disease. And if we go to the clinical point of view, I think you know, as women with Parkinson's disease, that you got dyskinesia earlier, maybe as soon as you started levodopa treatment. And there is a reason, because indeed there women with Parkinson's disease, they are more at risk of developing dyskinesia compared to men. Then you know that we have the non-motor symptoms, right? And you know that the non-motor symptoms are very typical in also in the before you get diagnosed with Parkinson's disease. So women they have more anxiety, they have more depression compared to men. But nobody asks for that, right? So, but it's very important, because we need to treat. And if we think that in the future we will detect Parkinson's disease earlier, and so we can have some neuroprotective agent to recognize these premotor symptoms a little earlier, will be very important, right? So we really need to go deeper in this big difference. For example, you can see here that men, they have more gastrointestinal issues compared to women. Sexual dysfunction is more prevalent in men. And cognitive decline, the contrary of Alzheimer's disease, is more prevalent in men compared to women. So when we need to start to study some drugs, we should take in consideration that men may respond less than women to medication which can slow down the cognitive decline in Parkinson's disease. It's very important to know that. Right? And this is a summary of studies that are starting to pointing out these differences. And as a physician, we need to ask these things. And you, as people with the disease, should help also the physician say, well, you know, I'm a woman, I feel this, I feel that, because sometimes we don't ask, we don't have the time, we don't think about. So we need really to shape the treatment, the care according to these differences. This is just a publication. We have a big journal in movement disorder, very important, which recently stressed, as you can see, that there are differences between female PD patients, they say. No, as I said, they have a higher risk of dyskinesia, but it looks also that the disease is less severe in women compared to men. But we are talking about a big population. They are the first studies. Again, we need really to focus on several aspects. As I said, this lady who after DBS was really doing a lot of stuff for the family. Why the lady they do that and men are a little more passive, right? So there are reasons we need to understand. And as I said before, this is why, as a neurologist, at least the community of physicians, we think is very important to get the attention of our colleagues. As I said, the residents, the medical students who are starting now, right, becoming a physician, they need to be more aware that they are the next generation who have to take care of us, and they need to be involved. And this is the reason why we put together this task force in the European Academy of Neurology to get the interest in our colleagues to this area, and also for us to do more research and to help our people with the Parkinson's disease in our small community. And I hope that this starts the discussion. So I stop, share, and I get back the stage. I give back the stage to you, Indu.
Sure. Thank you. So one of the questions that had come up, thank you for that amazing body of work and really all the advocacy and stuff like that. Before I move on, I just wanted to clarify, somebody had asked about what the difference between sex and gender is and how we're defining it. We actually put that in our paper, and so I'll just read that because I think it is important to understand that. So sex refers to the different biological and physiological characteristics of males and females, such as reproductive organs, chromosomes, and hormones, while gender refers to the socially constructed characteristics of women and men, such as norms, roles, and relationships of and between groups of women and men. So they're sort of two different terms that we're using, and that's the definition. So I think we'll also, there's also a question about how it is between the US and Europe in terms of medical school knowledge. Maybe, Elena, you could tell us, since you've worked both in North America and in Europe, do you feel like these are things that are being sort of worked on a little bit more aggressively in Europe or in the Americas? What's your sense?
Maria Teresa can also add something. I think in terms of neurology, there is not too much. For example, we know that in the United States, there are some faculty of medicine, right, that they have a special fellowship in recognizing, I think more in internal medicine point of view, differences in sex, but in neurology, there's nothing in the, at least at the faculty of medicine level. There is in Germany, to my knowledge, and I didn't see also in the American Academy of Neurology big differences or groups focusing on that. In Europe, there is Germany, there is the Netherlands, Switzerland, with in some schools, not in all the faculty of medicine, that they have a space for gender medicine during the medical school. Right, so, but never at a specific, you know, in neurology, in the program, residency program, in neurology, you have this, that it doesn't exist. This is what we want to do, right, to really try to put in with the resident. We have some residents in the task force to, and we are developing an e-learning program in which we want to point out the gender differences in all the neurological diseases.
Absolutely. I just, there's a comment here that it was actually a private comment to me by Jason Flatt, who was one of our speakers as well. He spoke about LGBTQ issues. And I was wondering if we could try to locate him, Andrea, because I think it would be great for him to talk about. He did a survey. His main focus has been on Alzheimer's disease and dementias before. And
this is where we need.
Hi there. Thanks for having me. Yeah, I just wanted to highlight some work that we've been thinking about in the dementia space, and specifically asking, so what we did was a survey of some of the across the US with the Alzheimer's disease research centers, and then any like funded Alzheimer's disease kind of studies or have an intersection with aging. And so we asked for protocols in their surveys of how they assess sex and gender, and then had some specific questions around like, right, how are you assessing it? Is it self-report? Is there, you know, are you assessing gender identity? Sort of trying to tease this out. So we have a paper coming out in the Journals of Gerontology this month that highlights some of those findings. And so, and really what we're seeing is a lot of inconsistencies, right? Of like, some people follow, so there's the National Alzheimer's Coordinating Center's recommendations. Some people follow that. Some people don't follow any of it, right? And then most are not asking gender identity. They're really focused on biological sex, but they aren't even asking biological sex in the question. And then the larger issue with a lot of the aging studies that we found is that it will be based on the interviewer's assessment. So they don't even ask about identity. They just make an assumption based on physical appearance, the vocal timbre of someone's voice, right? And so this is a huge issue if we're going to understand truly the unique needs, differences by biological sex, but also thinking about gender identity, because we know that even how people navigate the world in their gender expression and their identity, right, affects their experience. So that's some of the work that's coming out. But I was wondering, is any of this happening in the Parkinson's research space, specifically looking at how is it being assessed across all the studies? And is there, and then come up with some recommendations of how can we change this so that we stop doing it the way that currently is happening?
If I can make a comment, Indu, first of all, Jason, thank you so much. It's so nice meeting you, and congratulations on this piece of work. This is very much needed, and you might have seen me nodding. And I just want to share an anecdote with you, because I had exactly this problem when publishing the latest paper that we had on sex and gender differences, let's say, in enrollment of women in clinical trials for Alzheimer's disease. That was the topic of our meta-analysis. And we did a very simple exercise, just checking clinical trial data and seeing how many men, how many women were enrolled. And when it came to writing the paper, actually, we did not know how to refer to this. So are we looking at sex differences? Are we looking at gender differences? And some reviewers told us this is gender. Some reviewers thought it was sex. I came to the conclusion that actually we didn't know either of them, because in most cases, as you said, it's evaluation that the interviewer does, not based on any biological analysis, nor asking for the gender identity of the person. So it's just made up. And it really gave me the sense of how far we are, because if we are not collecting this type of data, there is no way that we capture, exactly as you said, the specific need of different populations. We are not seeing them. We are just, labeling people based on our ideas of what should be a man, what should be a woman, and we are missing out a lot of important data. So I think your study, and especially the recommendations that will come out of it, will be very useful for Alzheimer and in general. So thanks.
And if I also say that some journals, like the New England Journal of Medicine, has just recently published a statement in which they will ask officially all the clinical trials publication to state clearly gender and sex in the data. So it will become, extremely important if you want to publish in a very important journal to clarify these issues.
Yeah, I think that there's a huge gap there, and I think it's really important to include that. So just to help the audience understand kind of what sort of topics we've covered on this series to date, Jason and I had a great conversation about largely around LGBTQ issues, so I definitely refer you to that. There was a panel that both Dr. Ferretti and Professor Moro were on in Europe, and I believe that's on video, probably floating around somewhere. And then we did a panel with a number of voices, including women living with Parkinson's, some of whom are healthcare providers, including Rochelle Flanagan, who has some questions, and I'm going to bring her on. And so I refer you to that, as well as a beautiful chat interview that I had with Dr. Oostergan Enelen, who is a woman living with Parkinson's, who is an OBGYN. We covered in that some basics about the hormone cycle and different sorts of thoughts around the various phases that women go through as they age and go into the perimenopausal, menopausal timeframe and beyond. So I refer you to that because we may not get into the nitty-gritty, but we have had a number of great chats, and all of them are on YouTube, and perhaps the PMD Alliance folks can link them in the chat here. So Rochelle, I know you had some questions, so maybe I'll have you ask maybe one or two of your most pressing. You always inspire us, Rochelle, with your voice and your sort of questions and inspiration just energetically. So Rochelle, Rochelle is a dietitian in Ireland and is a woman also living with Parkinson's. So Rochelle, over to you.
Thanks very much. No, it's fantastic seeing all the research being presented again. And I just wanted to ask, in terms of, what does the neurological field need to do to advance personalized medicine like it is done in cancer? Like, what do we need to do, both the professionals and the advocates to make that change happen quicker? That'll be one question.
Yeah, Maria.
Okay.
No, Elena, please go ahead.
No, you start with your scientific point of view, and then we will be more practical.
Well, I have a comment, and so I have a personal experience and my personal idea of what is missing there, because I had a personal experience with oncology and precision medicine in oncology of breast cancer. So I can testify as a patient of how powerful it is, a personalized approach, and knowing exactly what you have and what you need, and being given the treatment that is targeted exactly for your pathology. That happened to me and saved my life. So I'm very passionate about this. And when I saw it in oncology, and I had my diagnosis in 2 weeks, and the full molecular characterization of my tumor in, let's say, a month, and the whole therapeutic plan decided in a few days, and everything was done in 6 months. If I think of neurological patients that have to wait for years before having a diagnosis, and even when you get a diagnosis, in many cases is not sure 100%. Alzheimer's is always a probable diagnosis, and there are no real specific treatments. I mean, I could see the distance, right? And how is it possible that one field of medicine is so advanced, and in neurology we are still there? And the one thing that, if I could ask Santa for a present, for helping neurologists, what I would like for Christmas is actually biomarkers. I think what we are missing right now is a detailed characterization of the pathology from a mechanistic point of view, with biomarkers that can define exactly what a patient has. And biomarkers will be different also according to sex, gender, ethnicity, and a number of other things. So the moment we move away from, not move away, but integrate the clinical diagnosis with something that we can measure and that we can compare across groups, I think that will help incredibly moving forward towards personalized and precision medicine. But that's my, it's really coming out of my heart. And Elena, I leave it to you.
I think what you said is important in terms of awareness, right? If the people with the Parkinson, they go and see the neurologist and say, I'm a woman. If there is any difference as a woman with my disease, so should I have a different medication? Should be aware of something that can be different when I get older and the disease progresses. So this can be a question that can stimulate the neurologist to say, I never thought about that, or maybe I have to read a little more. So this is, I think, what as a person with the disease is important to do. Then, from the research point of view, besides the gaps that we are talking about, animal models and including more women, right, in the clinical trials, I also think that we will have answers, right, with the study of the microbiota, the genes. Like in COVID, we see that the difference between women and men. So we are discovering that the immunitary system is important, and women is different compared to men. So this, the new knowledge about not biomarkers, as we talked before, the MRI, the functional MRI, the fibers, they will help in personalized then the treatment. But I think that physicians should do a part, but also people with Parkinson's disease, they should help the physician to understand that it's not the same. So there are differences and we have to work together.
Yeah. Can I ask one other question? And that is just, I came across a paper quite recently, and it was 4 case studies of young women who were pregnant with, were pregnant, and their Parkinson's symptoms basically appeared. So they were diagnosed during their pregnancy. So they basically developed Parkinsonian symptoms and were subsequently diagnosed with Parkinson's. I actually experienced that myself in terms I was 3 months pregnant, and I actually noticed myself I had micrographia. So I'm just wondering, in terms of, we've discussed before how women with Parkinson's have worse symptoms prior to their menstrual bleed. Is there similar potential around pregnancy because of the hormonal surge, that this could, push women who may have a prodromal, Parkinson's, and the hormone surge, sets off the Parkinson's? I was just wondering, is there any thoughts about, that?
Do you guys have a thought? I mean, I think that I'm not 100% sure about the hormones per se, and I think in our paper we didn't find any clear data on that. But I think that it is a stressor to be pregnant. I've been pregnant 3 times, and a lot of diseases can either get worse or better, sometimes with the immune sort of modulation as well of, that. So it may not just be purely hormonal, but there might be other immune things that happen during pregnancy. But I would say it is a stressor. And I certainly think that, many patients have said that, they've sort of linked some of their onset of symptoms to their pregnancy as well. So I think that's not just anecdotal from the few cases that you've spoken about. I think more research has to be done. But do you guys have any other thoughts on that, Elena? Or
I think it's difficult to say. It's very difficult to say.
Yeah.
No, I don't think there are very solid data out there, but my general thought is that in general, for a lot of brain and mental disorders, all these periods of life where you have very profound hormonal changes in whatever direction they go, whenever there is a change in your hormonal status, you are at higher risk for a number of disorders. And also with migraine, it happens. Some people, when they go into menopause, they are finally freed of their migraine, and some people actually get migraine when they enter menopause. So it's hard to predict in which direction it will go, but the hormonal changes itself seem to be a trigger. So this is one of the things that we should actually try and understand a bit better from the scientific point of view. I think it's fascinating, but I don't think we have enough data right now especially for Parkinson's.
Yeah, and people are saying did anecdotally also make their symptoms worse or kick off their Parkinson's as well. One or two things to clarify. Andrea had asked if we could clarify this, Elena. The question that women should ask when they go to see their doctor, how should they frame it? Should they say, I'm having these symptoms, could it be because of this phase of my cycle, or what should they sort of say as sort of a patient? That would be a practical thing to help their physician maybe care about this sort of the fact that they're a woman and that these things may be influencing them. How should women approach things?
I think it depends on the age, right? If you are menopausal, you might, or after so many years, maybe there's no particular relation to that, but you can focus in asking specific questions. I would say, as I said before, just simple, right? So there is any difference between sex and gender in the treatment, or if they think that if they're young and during the periods there is a worsening of Parkinson's disease symptoms, they might point it out. So I have, especially during this time, my motor fluctuation, they are worse. So what do you suggest to do? Is just specific and simple, but pointing out that there might be differences, and they ask how to deal with them.
Yeah, absolutely. I think bringing awareness to the physician is absolutely important. And I think, it seems so bizarre that in 2021 that so little work has been done in many of these spaces. But I think some of these papers that are being written, and hopefully this one that we'll be publishing hopefully soon in movement disorders, will be a place where, patients can refer their doctor to, go read about this. And I think, also in answering your question, Rochelle, about the, how do we move into sort of a parallel universe, like in the cancer universe? I think the advocacy in cancer is huge, right? I mean, I think, the general public thinks this is a life-threatening disorder. There's a huge amount of funding in many of these things. We have to sort of raise the voice of Parkinson's patients and say, as you guys are doing with the PD Avengers, for example. So people out there that are listening, Rochelle has linked the PD Avengers website, but I think it's a great sort of global collaboration of patients people living with Parkinson's, of various sort of ethnic diversity, gender diversity. So rally together, get in groups. I know Rochelle has one in the UK, some WhatsApp, Facebook, whatever, just trying to share common experiences sometimes so that you realize that you're not alone, and that you can, take those voices, not just the one voice, and say, that these things are important. And I think as we're doing with healthcare providers as well, I think the more, sort of collaboration. I think Zoom has made this sort of a nice way that we can, globally collaborate. And I know that there's a lot of women, there's a group that I had spoken for in Spain, trying to bring together, women living with Parkinson's that are Spanish speaking. So, really look for advocacy organizations, try to connect, try to, sort of share experiences and then amplify those voices, I think is really what I'm hoping to sort of do with this series. And I think we have to do more of, and then collaborating across, silos. So Jason, for example, Dr. Flatt, he is a researcher in the LGBTQ community historically, but I think many of the thoughts that are in, for example, gay men who may not have a partner, they may not be married, looking into how can we then use maybe friends or other people as advocates in our lives than if we're a single woman or a woman who may be married to somebody who may not be the best sort of advocate for us. How can we share these voices across silos? So I think we really have to break down barriers and think across into the Alzheimer's space, into cancer, into other things, and see who's doing work that resonates with us and try to learn from it, because I don't think it makes sense to reinvent wheels if we can just sort of share, which is what I'm hoping to do more of. So great. They're asking if the Women's Brain Project take patient members and how can they help with the work, is a question. Dr. Ferretti.
Absolutely. So I'll try and see if I can send you a link. But yes, please check our website, womensbrainproject.com. Membership is open to everybody, and we are particularly happy to have patients on board, especially if you want to help us in scientific projects and giving us your ideas and steer and direction steps. That's always a possibility. Actually, we are very actively looking for that. So thank you. Oh, great. I see it in the chat. Thanks a lot. That's very efficient.
Yes,
and also, Indu, I want to ask that I think as a physician, we should, inside the bigger society, push into differences in the treatment, right? Because in the guidelines is a bit difficult because we need randomized clinical trials to say that. But I think we should work in some groups and try to differentiate the way that we start the treatment in between women and men. As I said, for the dyskinesia, for the non-motor symptoms, we should work on these things because we can set up some recommendations which are not available yet to avoid, severe dyskinesia, severe motor fluctuation. So how to manage a little better. I think we should also with the patients organization, I forgot to mention that you have in the United States, the Parkinson Alliance and strong power, and also in Europe there is the EFNA. I think we should work together with that because they are very important that to recommend neurology to start with some treatments instead of others.
Absolutely. And I think women, our paper with which hopefully will come out, it really was emphasizing some of the psychosocial aspects of this too. And women often don't find themselves important enough to care about themselves. We're caregivers of other people. We often don't come forward. We don't participate in research. We don't complain to our doctors about things that are happening to us because we think that we're going to be dismissed. The healthcare system is not really set up in most of the world to really proactively care about these things. So if you're suffering with symptoms and that are not being addressed, you have to advocate for yourself. Find other women with Parkinson's that are doing this work. I think Rochelle has put some of the Twitchy Woman is a woman who runs a group here, who's one of my patients that has a lot of online following. They have some mentorship between women trying to advocate for each other. So again, think outside the box. Think about ways that you can find a buddy, maybe with another woman living with Parkinson's, that may be able to be your partner in crime to help, raise these voices. So I think we really have to come forward and complain and be heard and, elevate and amplify these voices and the care. We have 2 minutes left. I'll let each of you ladies have 1 minute to close with some sort of, hopefully girl power kind of shout out to the group out there. And And thanks again, PMD Alliance, for hosting these awesome events. Go ahead, Elena, I'll let you say wrap up.
Well, what I have to say that we have exciting times coming to help people with Parkinson's disease and the neurologist and the caregiver to take a more, to acknowledge a little more these differences and to improve the management of this difficult disease.
Great. And Dr. Ferretti, I'll give you the last minute.
Yeah, Elena gave it beautifully, but I just wanted to mention something about women and how we stick together. I think somebody also put a comment in the chat. Women are often seen as the chief medical officers of the family. I mean, we are deeply interested in health, and whenever you run a survey about any health issue, it will be 80% responders will be women. I think there is an enormous power that we should leverage for improving health in general, because the moment women are mobilized to take care of their health, there will be like a snowball effect on the whole family and on the whole society, and it will benefit not just women but also men in the end. So it's again a call to action to get involved, be an empowered patient, be an activist, and work together with all the other stakeholders. And the Women's Brain Project is very happy to work with you all. So looking forward.
Well, thank you so much, ladies. This has been awesome. And I think, yeah, when women get together, there's no stopping us. So we just need to get together and advocate for each other. Even if we don't advocate for ourselves, sometimes I find myself advocating for other women.
Thank you also to all men who attended. Because
absolutely.
I'm going to pass it back to the PMD Alliance gang. Andrea, thank you for hosting. We'll have our goodbye wave.
Yes, what a great note to end on. We always close with a wave of gratitude. Invite you to turn on your camera and scroll through and see all the allies out there. Thank you for joining. Thank you for your amazing questions, and thank you to everyone who spent this hour with us. Bye now.
Thank you.